So let us now talk about excessive fibrinolysis. This is defined as the excessive activity of plasmin, which, if you remember, is produced by the actions of TPA and UPA on plasminogen. So plasminogen is converted into plasmin via TPA and UPA. Remember also that TPA and UPA are activated by fibrin, so as soon as the fibrin clot has formed, the fibrinolytic system is activated. If you cannot remember this, please go back to our secondary haemostasis video to refresh your memory. Now, in normal circumstances, fibrinolysis is responsible for fibrin clot degradation. In the case of excessive fibrinolysis, which is pathological, we have overactivity of plasmin for whatever reason. So just to refresh our memories, fibrin activates the fibrinolytic system, so it activates TPA and UPA. These go on to convert plasminogen into plasmin. Plasmin then degrades the cross-linked fibrin into fibrin degradation products. So this is what happens in normal circumstances. However, in pathological excessive fibrinolysis, there is no clot to degrade. Therefore, plasmin consumes coagulation factors and serum fibrinogen. So something can trigger TPA and UPA to convert plasminogen into plasmin. So what we end up with is increased plasmin and decreased coagulation factors. This all in turn leads to increased bleeding. The etiologies of excessive fibrinolysis include DIC, where we have increased fibrin formation and thus increased fibrinolysis; liver disease, as this is the site of fibrinolytic inhibitor synthesis; metastatic prostate cancer, so we end up with excessive local production of urokinase; radical prostatectomy, this ends up also releasing urokinase, and the reason for this is because urokinase is expressed in the prostate and is involved in various pathologies of the prostate. The research into this is still ongoing, and I've included a reference if you're interested in reading. However, this is not compulsory. Other causes include trauma and cardiopulmonary bypass. The main ones I would focus on are liver disease and prostate pathologies, including prostate cancer and radical prostatectomies. The clinical features of fibrinolysis are similar to that of DIC. So we have excessive bleeding. Again, this is due to the overactivity of plasmin and subsequent decline in coagulation factors. So again, you might see bleeding through the IV lines, mucocutaneous bleeding, etc., etc. So let us consider the following investigations. Again, pause the video and have a think at what you might find. The APTT and PT would both be increased. If you remember from the pathophysiology, we have consumption of these factors or of the coagulation factors by plasmin, so this in turn would result in an increase of APTT and PT. Fibrinogen degradation products, or FDPs, will be increased as fibrinogen is cleaved by plasmin. However, D-dimer would be low or absent. Again, remember from the pathophysiology, we do not have any fibrin clots to break down, so D-dimer would not be produced, but we do have fibrinogen in the blood, and this can be cleaved to fibrinogen degradation products, but not D-dimer. D-dimer is always the breakdown of the fibrin clots. Platelets would be normal, although the bleeding time would be increased. The reason for this is that plasmin can also inhibit platelet aggregation. Here's a question for you. Would you find schistocytes on blood film? Have a think about this. The answer is no, because again, no clots have formed. In terms of treatment, this is quite straightforward. Patients have excessive fibrinolysis, so you want to inhibit this. You would do this using an antifibrinolytic agent. For for example, tranexamic acid. Please like, subscribe, and share our content with your friends and on social media pages. Our mission is to develop need-to-know video content and question banks that remain free for your use. We are unable to keep doing this without your support. Thank you.